history of Waldenstrom macroglobulinemia already discussed by Dr. Uday. I am not going into detail of that. It's not a very old disease. First scientific publication in 1944 only by Waldenstrom, and basically MGUS usually maybe IgM MGUS and non-IgM MGUS. IgM MGUS usually develops Waldenstrom, and non-IgM MGUS usually develops multiple myeloma. So that is the main issue. But what is the underlying mechanism? That is the MYD88 mutation. A few points about MYD88 mutation. We all know there are three subsets of B cells. Initially, a naive B cells enters the germinal center, and from there, at the TB area, it gets activation with the new antigen, and then either it becomes a memory B cells or a plasma cells. Plasma cells may be short-lived or long-lived, and different expression, different flow cytometry parameters can define different subsets of B cells, different memory B cells and plasma cells. And what happened in Waldenstrom macroglobulinemia? Just this diagram is very important. MYD88 is a myeloid differentiation primary response 88 protein. Its normal function is the execution of innate immunity. Innate immunity is mediated by the Toll-like receptors, and MYD8 down signaling through the NKB kappa pathway and involving the Bruton kinase, tyrosine kinase pathway. It executes the production of different cytokines and interleukins in response to any PAMs or DAMs which are the antigen for innate immunity. And in this particular disease, MYD88 mutation, a particular mutation, that is leucine to proline mutation at the position 265 in the MYD88 protein, that occurs in 95 to 97% of the patients. Another important mutation is the CXCR4 mutation, which is 30 to 40%. So I will not go into detail of this all mutations. It will be dealt with some another person. I will just going for the data. So this is the paper which is published in 2019. That is the from our medical college, and we have reported first case series, proper case series of Waldenstrom macroglobulinemia with 29 patients. There is a median age of 65 and mostly male predominance. And this patient have varied presentation, very few cases with hyperviscosity or cold AIHA. We treated the patient with available treatment option. At that time, Bruton kinase inhibitor was not available with us, and most of the patients were treated either the RCD regimen or VDR regimen, that is bortezomib, dexamethasone and rituximab. And RCD is that there are higher mortality and treatment related complications in the VDR arm, and the BR arm is the beta arm. This was till 2019. For this meeting, I has re-evaluated all the data, analyzed all the data, and this is a single center retrospective study, and we have taken patients of Waldenstrom diagnosed at our center from 2012 till February 2024 over a period of 145 months. A follow-up till March 2024, and median follow-up duration is 22.5 months. 46 patients were diagnosed with Waldenstrom. The median age for this patient is 65 years with a range of 47 to 85 years. Mainly 82.6% male predominance. Lymphadenopathy in 39.1% cases. hepatomegaly in 15.2% cases, splenomegaly in 23.9% cases, lung lesion in only one patient, and hyperviscosity in one patient. Baseline lab characteristic, the mean hemoglobin is 7.6. The mean creatinine was 1.4 and median albumin was 3 gram and median LDH was 392. The mean M band, which is the IgM kappa M band in 41 patients, 89.1% cases, and IgM lambda in 5 cases only. The mean kappa lambda ratio was 2.9. The mean bone marrow lymphoid cell infiltration was 57%. MYD88 positive patients were 23 out of 25 patients we tested. 92% cases were positive for MYD88. We did not take the MYD88 in older patients, 21 patients, and currently we are evaluating all our Waldenstrom patients with MYD88 and CXCR4 mutation, and we are randomizing them based on their reports to acalabrutinib versus VR. Regarding the risk stratification, the very low risk, none of them were very low risk. 2 patients were low risk, 8 patients were intermediate risk, 21 patients were high risk, and 15 patients were very high risk. So we have more number of high risk and very high risk patients. So as Dr. Uday was telling in his talk, we should have so many cases of Waldenstrom as per our population, but we are getting very few cases. Probably this is the tip of the iceberg. We are missing all the cases who have asymptomatic or MGUS, IgM MGUS kind of monoclonal bands. These patients, out of these patients, 15 patients did not opt for treatment. Either they were not symptomatic or they were not financially affordable. 2 patients expired at the baseline and 29 patients underwent therapy at our institute. Out of this, 9 patients received the BDR treatment, 7 patients received the RCD treatment. R-bendamustine was given to 8 patients and R-CHOP was given to 4 patients. One very frail patient just treated with Lendex. Regarding the response, after first line of treatment, CR was achieved in 2 patients, VGPR in 1, partial response in 9, and stable disease in 4 and progressive disease in 2. With this data, we can say that most of the patients will achieve partial response. CR or very good partial response is not our target for this kind of low-grade lymphoma. 5 patients were lost to follow-up after initiation of therapy, and hence response assessment was not done in these patients. Relapse, 7 patients has relapsed after first line of therapy, that is 24%. 1 patient expired at relapse due to disease-related complication. Out of the rest 6 patients, 3 received R-Benda as a second line. 2 patients received BDR as a second line, and 1 patient was lost to follow-up after relapse. 1 patient who had received R-Benda as second line had second relapse also, and he was started on acalabrutinib. Currently he is in remission. Total 4 patients expired. 2 patients expired at baseline due to the disease complication in the form of hyperviscosity. This patient presented with Bing-Lin syndrome and he ultimately died. And 1 patient expired at first relapse due to sepsis. 1 patient died in second relapse. due to an accident which is a non-disease unrelated. There are other papers, and these are some papers of Waldenstrom from India. There is a bigger series from TMH and PGI Chandigarh, but these are not papers, these are just conference abstract, and there are some case reports also. With that, I thank everyone. Thank you.
So, Dr. can open for discussion, please. Are there any questions? Thank you, Dr. Sanjeev. I have just one question.
Yes.
What is the carry-on message from your side, this series? Would you want to comment upon the treatment modalities or any preventable cause of death?
Basically, if any patient has any symptoms in the form of neuropathy, or basically Waldenstrom is a link between lymphoma and myeloma. Some features like myeloma, some features like lymphoma. It's a link between lymphoma and myeloma. In routine investigation, we found some patient has MGUS, and that MGUS is a IgM MGUS. We should follow that patient serially. Some of them may turn out to be Waldenstrom in later life. Waldenstrom is typically CD5, CD10 negative lymphoma. Usually for lymphoma baseline immunohistochemistry, we did 3-4 IHC that are important, that is CD10, CD23, CD5 and CD10. These are classically CD5, CD10 negative lymphoma, and classically 90% of them are MYD88 positive. If we screen these patients with MYD88, almost 90% will be positive. And the best thing is of Waldenstrom's microglobulinemia is it has very indolent course. It is like an indolent lymphoma. It is incurable disease. Patient will not cure of the disease, but there will be remission, and it will be a long-term remission. And in subsequent relapses also, treatment is available, and if patient has very much aggressive features, there is an option for autologous transplant in first relapse also, and these patients can live a life of 10 to 15 years with proper management, proper treatment, proper management.
What are the current drugs available?
Normally, symptomatic Waldenstrom. Asymptomatic has to be just wait and watch. Symptomatic Waldenstrom, BR regimen is the best regimen which is used. Protein kinase inhibitor can be used for patients who are CXCR wild type and MYD88 mutated. Acalabrutinib, ibrutinib or janabrutinib, all three are approved by the FDA. There is an Alpine trial, and it has shown that upfront treatment for with BKT inhibitors, they have a better progression-free survival and overall survival. So that's why patients who are unmutated for CXCR mutation but mutated for MYD88, BKT inhibitor is the way to go. In all subset of Waldenstrom macroglobulinemia, BR regimen is the way to go.
This autologous stem cell transplantation is after the failure of kidney?
Yes, usually it is offered at first relapse. No upfront transplant for Waldenstrom macroglobulinemia like multiple myeloma. In multiple myeloma, we do the CR1 transplant. As soon as patient's disease load is low, either he is in CR or VGPR, we do the transplant, but not in Waldenstrom, usually in relapse setting.